Thank you so much, Chrissy. That was a nice trick at the end of a long afternoon to just throw in, hey, what about expanding scope of practice? I imagine there's some opinions about that in this room, and with that, we are happy to take your questions. I might just remind folks that a question is a query. You're seeking information from our esteemed panelists today. You may, or one sign that you're asking a question is your voice actually rises at the end of your sentence, which is often shorter. While you're formulating your questions, I'll exercise moderator's prerogative here for a second and maybe go down the line and ask our panel, if we were to reprise this panel next year and you were sitting here, we're sitting here in 2021, what was the biggest change that you saw in the last year with your group? So, Hemi, what, when you're looking at, talking with the governors, coming up in 2020, what's going to be the biggest change that we'll all see? And we'll kind of go down the line.
That's a tough question. I think the governors this year are really focused on, especially those governors that have been elected in 2019, which includes your governor, and really want to do a lot in their second year because they're kind of at the midway point before then they have to think about re-election, which, is your third and fourth year. So I think there will be some more movement on prescription drugs across the states, some more movement on surprise billing. And I do think one thing I didn't get to because I ran out of time, multi-payer alignment. So we are seeing in a number of states, really frankly Democratic states and smaller states in California, focus on cost benchmarks. So kind of starting with the Massachusetts model where there is a benchmark for all spend. And we're seeing it now pop up in Rhode Island, Delaware, Oregon, Connecticut is now interested, and there are a couple of other states. So I think that is going to be a trend to watch in 2020.
Great, thank you.
So actually, I think we already have alignment. I think you are going to see movement on drug prices, and whether it means disrupting existing PBMs or other intermediaries, there is going to be something done to address the cost of drugs. And frankly, I think there will be movement to create networks of providers that are actually demonstrably higher quality and lower cost.
I would expect to see two things as it relates to Be Well. First is I think the employers in the community will have recognized the value of this as it relates to the health of their employees and are taking a very active role in the leadership of moving the action forward, the activities forward. And then the second is something that we're seeing already, which is the effect of young people involved with this movement. We have a group of high schoolers, and they are all over this. And their use of social media and their ability to take this viral, if you will, and talk to so many more people about this than we ever could in a conference such as this or publications is pretty amazing. So I think those two will be major influences on the speed of this moving forward.
So we'll have had an election, so that is going to be a big driving factor in what kinds of policy changes we see over the next year. But that aside, one thing I'll be looking at is what is the experience that we see when Washington State has actually begun to implement its public option. How does that go? And is this really a model that other states would want to adopt?
There's a couple questions starting to come out. If you can get to a microphone, that would be helpful. Remind you to introduce yourself and then ask.
Hi, I'm Steve Ullman. I chair the Department of Health Management and Policy at the University of Miami in Florida. Great session, very appreciative. Question for Dr. Afable. It relates to mental health and it relates to also social determinants of health. It sounds like a wonderful program. My question is it focused primarily on acute services in that once people go to this center away from the ED, you mentioned that people will be visited wherever they are, home, homeless, prison, yet that's still homeless in prison that they go back to after an intervention. Is that a concern? And then related to that is immigrant population that has also a very high propensity toward mental health issues given all the stresses and strains on them.
Yes, thank you. Thank you for the question. And I tried to bring up the importance of other elements that relate to mental health. Like few other illnesses, the social environment has as much effect on mental and behavioral health problems as just about any other physical illness. And we saw the data on homelessness and on poverty and the effect that it has. While some of the specific actions are related to acute care, because that's what's right in front of us right now, we're calling that downstream work. There actually are three levels. There's upstream work, which is what you're alluding to, because you cannot separate homelessness nor poverty from this issue of, especially on the substance use side, but also the mental illness as well. And then there's in-stream work, and then there's downstream work. And I think a lot of the things that I mentioned are either in-stream, but mostly downstream. The real value, I believe, is going to be upstream. And so the upstream work, which is going to take longer, requires more cultural change in communities. Just the ability to talk about this in a more open and collaborative and generative way, where we're thinking as a community as to how we are creating solutions going forward. And so it wasn't intentionally to be focused on the acute care. It's just what's right in front of us today. But I think there is well acknowledged. And part of the coalition, there are many organizations, UCI being one of them, by the way, that are thinking about the social and policy aspects of this and being an important part of the long-term success. So the short-term success are more kind of what we talked about. The longer-term successes, I think, relate to just what you're alluding to, which are social determinants and how that fabric of the community at its best will be able to really get at this in a very meaningful way. Thank you for that question.
Other questions? I see one right over here.
This is for Richard. You mentioned Maricopa County. Were there any other counties where you looked to for when you design Be Well? My other second question is, are you doing anything to prevent behavioral issues in this model? And then finally, 5 years from now, what would you say is the metric that would say Be Well succeeded?
Well, tough questions. Let me try. Maricopa County, which again is Phoenix, Scottsdale, was the location where navigation was most well developed and showed some very meaningful results. They, on the other hand, have done little in the way of facilities or acute intervention. And so I mentioned 5% of their patients or their community members who need facility work, they go to emergency rooms, and we don't believe that's the right place. The place that has the most well-developed facility is in San Antonio, Texas, to the best of our knowledge, and we paid a visit. Many members of the coalition went to San Antonio. In fact, we've gone there 3 times. And there's an organization there called Haven for Hope. You can see them online. You can look at them and see what they've done. It was started by the retired CEO of Valero Oil, who was complaining to the city of San Antonio that there were homeless people down near the Alamo, and what were they going to do about it? Meaning, what were they, the city, going to do about it? And they turned it around and said, well, what are you going to do about it? And he said, well, I'm going to show you. The result is Haven for Hope, which is an incredible site in downtown San Antonio that has mental health services, it has crisis intervention, it has shelters for homelessness, it has permanent supportive housing, it has a federally qualified health clinic, and it has many other locations. So that was the place that we're thinking about for our second site. We would like to have a federally qualified health center right there engaged with, so we can get the medical and the mental side by side, and then put some permanent supportive housing in there and maybe even some shelter sites. And then the last question is 5 years. I think, I wish I knew exactly what the metrics will be, but I think if we get it right, we'll know it. I think we as a community will just say, this is substantially better. And maybe, just maybe, others coming to visit us as opposed to we're going to San Antonio or to Phoenix. Maybe others coming to visit us might be a sign that we maybe have gotten something right along the line. I think some of the usual metrics, I'm gonna talk to Amy about all the metrics because she's really good at that stuff. So.
Follow up to that.
I actually want to ask you a question, Hemi, if it's okay. We are right down the road from the medical school here in Irvine, and on your slide, I don't think you had a chance to talk about it, but workforce was certainly an issue that is rising to, or rising in governors' conscious across the country. To what extent is that really a priority, and what are some governors, what type of investments or reforms are they pushing for when it comes to medical education?
Yeah, it's a great question. I will say it rarely rises to the state of the states at the top of the list, but underneath that, I think there is a concern, and sometimes it's bundled into their other economic developments and thinking about globally. Okay, like where do we have healthcare shortages and how do we deal with this? So I would respond that I think some governors are thinking about how to invest in a pipeline to better actually address the needs of their state, but I think it needs to be more of a priority. Where we are working right now with a couple of governor's offices they're very excited about is understanding their data to then really drive the right policies, which would include investment in medical education and figuring out like what type of specialty is actually needed for particular locations, because some states have really good data on that and some states don't. And so I think there's an interest in that. I will also say Arizona is an interesting example. It's the first in the country to actually have reciprocal licensing, and that goes beyond healthcare. But Governor Ducey actually spoke about this at our NJ Winter meeting, and lots of governors were interested in it. And his idea is, how do we get more people to come to Arizona? And people already come to Arizona, but how do we get even more people to come to Arizona and want to work? And so I think that's something to think about for other states too, is there more reciprocity with licensing? And does that open up the doors for getting different folks, which would include healthcare workers, into different states?
Yeah. One of the things that really struck me about Rick's talk was this idea that we certainly don't want to be treating the mentally ill in emergency rooms, but we may never have enough facilities and never have enough providers. So I know, Chrissy, one of the cost containment options that you looked at was telepsych through the ED. And I'm wondering if what you found when you looked at that policy, like which states have tried it and what type of savings opportunity is available.
Right. Well, that's a good point. So there are a bunch of different initiatives to try to use more telehealth to not just for the population with mental health conditions that comes to the emergency room, but to expand or to address workforce issues in general. And there are a couple of different models of that. One is doing direct screenings through telehealth, which I think was the last example related to the mobile example that you described. And there's also something called the ECHO model, where it's a train-the-trainer kind of approach, where a specialist provider trains generalist providers to treat conditions that they can manage, so that everyone's working to the top of their licensure. So these are, important and potentially cost-saving approaches. We did find that providing telehealth in the emergency room for individuals with mental health conditions could be a cost saver, across the evidence that we reviewed. But there are many options to potentially save money here, as well as, I think, even more importantly in this case, is expanding access, especially to rural areas where there are just not enough providers.
Yeah. And Elizabeth, I want to bring you in here.
I would just add that several large employers are actually building out these clinics, primary care clinics, but not your traditional primary care clinics that include behavioral health practitioners, dental, vision, the much more sort of comprehensive holistic health. And they're really reducing cost barriers, and they're really just trying to meet the needs wherever they exist.
Yeah. Thank you. Yep, right here. Whoop, 1 sec, wait for the mic. And introduce yourself, please.
Cindy Enos. And Elizabeth, one of the things, you mentioned a number of employer initiatives, but one you did not mention is the Amazon, Berkshire Hathaway, JP Morgan initiative. And I just wonder, again, you had some great minds coming together to try and look at what was some maybe easy to do, but Can you update us on where that stands?
We actually met with Haven a couple times in the last month. I really can't say much, but it's not dissimilar. Investments in primary care, telehealth, really trying to ensure the highest quality. So direct contracting is really on the table, really raising the standards for quality metrics and really identifying providers who will meet those. So I really can't speak for them, but it's not dissimilar.
Any other questions? We're about 2 minutes away from happy hour, and I think people in this room are feeling it. One more over here, right in the middle.
Hi, I'm Drew Phillip. I'm a DNP student here at UCI. My question is for Richard. Being a millennial myself and being a social media user, I know that social media is a great platform to normalize mental health. And I feel that young adults and adolescents really understand the importance of mental health, and I feel like the stigma is broken. However, I feel like there's more of an issue with breaking the stigma with older adults and middle-aged adults. So my question for you is, what can we do to address that population and breaking the stigma for mental health?
I would agree with your assessment completely. It's more of a difficult issue. The stigma issue is certainly more prevalent in older individuals and not so much an issue with the younger adults. And that's one of the things that I was mentioning about the high schoolers. We were so surprised when they were so easily able to talk about it with each other. And, you know, to have a discussion of suicide, you can imagine older adults sitting in around a room having that discussion, but rather sitting with these high schoolers, just an open conversation. Oh yeah, he or she, had that problem and we did this and we did that. It's amazing. Cultural change is hard. It's very difficult. And I think it requires leadership. And here's an example where the young leading the older, as an older, I can say that the young leading the older, I think can and will have a significant impact. We know that millennials make up the largest population today, as the boomers are slowly leaving, and they certainly are the largest group of the workforce in healthcare and many other areas as well. So I think that the people like yourself and organizations like here at the school, you're in the program here. I think that your leadership will have a significant effect going forward when and where it's okay to have this conversation and talk about it. Since we have 1 minute, I'll just allude to the fact as a practicing physician, I have been around long enough to remember a day when you did not discuss testicular cancer. You did not mention breast cancer. And you didn't talk about ovarian cancer. That was taboo. You did not. That's personal. You don't talk about that. Now, 20,000 people will get together at Fashion Island and wear pink and run 5K to cure breast cancer. This will go through the same cultural change. It's going to take some time, but the specific answer to you, I think, is your leadership is what's going to move the cultural change for any generation going forward.
Well, I'm feeling great after this panel. Please join me in thanking everyone.